Sorry for the slight late start. We've had some technical issues that we will resolve, but I'm very pleased to introduce Dr. Krishnamurti, who's the director of the transplant program from Emory, and my colleague at Aflac Cancer Center. Krishna has been a leader in developing allogeneic transplant for the treatment of sickle cell disease, and he has led a multi-center national study that showed the feasibility of this approach, and was recently awarded a very large R01 grant from the federal government, and in partnership with the BMT CTN will take this study to the next level. So we're very pleased to hear about his very exciting results in using stem cell therapy to cure a really terrible disease. Krish.
Good afternoon. Thank you for putting up with the quote-unquote technical difficulties. It's my job today, as soon as the slides come on, to talk about sickle cell disease as an archetype of a disease that you can cure by stem cell transplantation. And a lot of the things that apply for sickle cell disease for transplant also apply for stem cell gene therapies. So I think this is really important beyond bone marrow transplantation. So it's customary to start with a conversation about pathophysiology. So the time after lunch is not a good time to talk about pathophysiology, but there is really no good time to talk about it. I'm only showing you this cartoon to point out that even though, as you see, do I have a pointer somewhere here? Or? No. So to want to point out that we started off thinking about sickle cell disease as a point mutation in the globin gene, and that causes a single amino acid substitution and polymerization, as you see on the left side, to really, no, I don't see. So see on the left side, there's a summary of what we actually know, that it's not just, there's a lot of downstream effects of hemolysis and vaso-occlusion, and so really there are two elements of sickle cell disease. One is vaso-occlusion, and second is hemolysis and the downstream effects of hemolysis. This picture is to show you that it's a disorder that affects multiple organs. The commonest and most important manifestation is pain, and pain, as you know, is a very ill understood and poorly managed condition, especially anybody else's pain. But stroke, pulmonary complications, renal complications, pulmonary arterial hypertension, bone problems, skin problems. So in short, sickle cell disease has a decreased survival. In the late 30s is the median survival, and has a quality of life worse than cystic fibrosis and cancer. So what can be done about sickle cell disease? So starting in the 1970s and 80s, there began a systematic approach to give comprehensive care. So we would now diagnose all children on a newborn screening in the 50 states and the District of Columbia, and then enroll them in this really all-embracing care that includes education, pneumococcal prophylaxis because the spleen stops working, and then early diagnosis of complications and treatment of pain, and give antibiotics. So gradually there's been an improved quality of life and improved survival. Starting in the early 90s, then we started with the next level of palliative care, which is drugs to increase fetal hemoglobin, such as hydroxyurea, for patients who've had a stroke and are at high risk for a recurrence of stroke, to get chronic blood transfusions once a month, and then treat the complications of chronic transfusions, such as iron overload with iron chelation, which was originally intravenous and subcutaneous and now is available orally. Or should we try to cure this disorder instead of trying to live with it or trying to palliate it? And I think that the curative approaches, and there's a lot of overlap in the two curative therapies, and I'll primarily talk about the stem cell transplantation, because that's my task this afternoon, but also gene therapy, which I'll briefly allude to. So it's a genetic disease, and the one thing about genetic disease is same mutation, many different phenotypes. So we're always faced with, who do you offer a serious and potentially difficult, expensive, and potentially lethal intervention with the aim of curing? So the general feeling within the community is the three factors we would take into account on deciding who would get a transplantation would be age, severity of disease, and the type of donor that's available. So the original studies, there were two parallel studies started for children and adults. Children did great, the adults did badly, and so for 30 years nobody did transplantation for adults with sickle cell disease, which is a travesty because by then the disease was really bad. And so we transplanted children who had a potential to do badly, but if they didn't get transplanted then, they went to adulthood, they were doing badly, and we said sorry. So this is changing, and I'll briefly talk about that. Because this is a disease which is not an acute illness, but a chronic illness, we were hesitant to willy-nilly offer the transplant to everybody, because especially the transplant is not a walk in the park. And so we came up as a more or less a consensus of criteria for disease severity. And these criteria have remained static over the years with very little change. And then the type of donor available. The vast majority of transplants have been done from matched sibling donors, that HLA identical donors, but the story is now changing with the National Marrow Donor Program and having more than 7 million registered donors available. And also the how we do transplants, we're getting a little bit smarter with that. Okay, move forward. Dr. Waller was going to give you the detail on what you do in transplant, so I'm just going to stick with one slide. So in summary, this is what you do in any hematopoietic stem cell transplantation. Is you collect the patient's bone marrow, or you could be collecting peripheral blood cells or umbilical cord blood. You may process it. Again, the processing may be red cell depletion, plasma depletion, or not. You may cryopreserve it, but if you didn't have to ship it somewhere else, you don't have to cryopreserve it. And then the patient gets chemotherapy to empty their marrow to create space for the new cells to enter the stem cell niche. And then you basically give it back and then maintain them on immunosuppression for a period of time so that they don't reject the donor cells, and also the donor cells do not attack them. So that's the graft and the host. And so the graft versus host disease is one of the really bad complications. So if you're in a rush to leave, I'll tell you what my talk is in this slide, and so then you will all be fine if you want to catch the bus. So what are the results for stem cell transplantation for sickle cell disease to this point? So there are excellent results of BMT from matched sibling donors. So what's the problem with that? Availability of donors. So by pure mathematics, there's only a 1 in 4 chance that your full sibling will be a donor. But in actual fact, with small families and melded families, that chance is actually closer to 14%. So 85% of the patients are not going to have a donor available. The other issue is really a social issue, that you can have the best transplant center in the world down the road, but you don't have access to it, you don't have awareness of it, your primary care sucks. So these are actually not trivial issues, even though the curative treatment is available. Today, bone marrow transplant from an unrelated donor is feasible because we have the National Marrow Donor Program. More than 7 million people have registered to be donors. But the challenge is, again, these are African American patients. Most of the patients come from donors are people who showed up to donate blood. You know, blood donors are 98% Caucasian. And so here we have a disease that predominantly affects African Americans, and you don't have enough donors. Only 19% of African Americans will find an 8 out of 8 HLA matched donor. The other issue is graft versus host disease, which has no advantage in this condition, but the fear that you will lose one bad morbidity to get a second bad morbidity. We now know that bone marrow transplant in adults is effective. This is all work that's happened in the last 3 to 4 years. Again, availability of donors. If you think that children have a problem with access to care, you have to see what happens to adults. It's really heartrending. And then unfortunately, they may be too sick to get a transplant. And then bone marrow transplant from haploidentical donors. This is exciting. So we always wanted to match a full match, as your only full relative is your full sibling. And so therefore, if you didn't get that, it was too risky. And now that we have new approaches where you can get a half match, which means both your parents are half matched. So potentially everybody could get a transplant. And then finally, gene therapy studies are open. There are some preliminary data that are quite exciting, but then these are all gene transfer, lentiviral vector. Who knows what the future will bring? So it's too early to talk about that. So that actually is the summary of my talk. Should I keep talking, Ned? Okay. Earlier this week on Monday at the American Society of Hematology meeting, this study was presented of all the results in everywhere in transplantation for sickle cell disease is 1,000 patients in 88 centers in 23 countries. So this is the most recent data. As you can see, there's only 439 patients transplanted in the United States, and there are 100,000 patients with sickle cell disease in this country alone. The majority of these patients were transplanted from matched sibling donors. Remember that 14%. And what are the outcomes like? Fantastic. So the 3-year overall survival is 94%. So for a bone marrow transplant, physician, that is just unthinkable, unbelievably good. And then this picture shows you that for the different types of stem cell donors, so the blue arrow is bone marrow, the blue line, the red line is peripheral blood stem cells, and then the green line on top is umbilical cord blood stem cell, again from a sibling donor, and looks like Matt's sibling bone marrow, which is the commonest, has that's the 94% outcome. Cord blood, much smaller number, just 89. The outcome's really good. What proportion of patients are cured? 90% getting bone marrow transplant are cured. So this is in the realm of dreams. This is such good results that we don't get in any other condition. So naturally, the community has sat up and taken notice of it. So these are the transplants reported to the CIBMTR until 2012. And as you can see, there's a quantum leap in the number of transplants starting 2007. And the important thing to notice is that this not only indicates people want a transplant, people want a cure. So so those of you who are thinking about doing gene therapy research should take heart from this, that there is a real demand for curative therapy for sickle cell disease. So excellent outcomes with matched sibling transplant. Conditioning regimens are well tolerated. They have good organ function. Results have been reproduced in 23 countries, and low incidence of long-term sequelae, 90% cured and doing well. So what is the problem? Well, this is not a walk in the park. It's probably about as severe a treatment as you can get this side of living. A lot of the time, that's what it is, even though we're making it better. Graft versus host disease is real risk of exchanging one bad morbidity for a second bad morbidity. We're giving chemotherapy. There's a very significant risk of treatment-related malignancy. It costs a lot of money, several hundreds of thousands of dollars. It's not available to most of the people in the world who have sickle cell disease, who half of them live in 3 countries, Nigeria, the Democratic Republic of Congo, and India. So you can imagine that we cure our 400 patients and we're happy, but it's not actually getting to people who need to have it. And so the other issue is that until now, Centers for Medicaid was not routinely covering transplantation. And so we hope that as of January 2016, this coverage will happen. Okay, how many minutes do I have? Okay, all right. So let's then talk about what we need to do. Unrelated donor transplantation, because only the minority of people will have a related donor. What are the results? So these results again were presented at the same time on Monday. So this is a BMT clinical trial network study. So they used umbilical cord blood from an unrelated donor or bone marrow transplant from an unrelated donor, and the engraftment from the umbilical cord blood arm was poor, and they had to close that arm. Of the patients who received a bone marrow transplant, overall survival was 86%. So 14% of the patients died from the treatment. So overall survival and cure was 76%. So the study goal was if you're better than 75%, it's success. But I think as a sickle cell doc, I'm not happy saying I cured 3/4 of the patients that went through this horrible treatment. Graft rejection, 10%. So there's something about sickle cell disease that makes engraftment, sustained engraftment difficult, and that may be related to their bone marrow being hyperactive, there being chronic inflammation. And so there may be roles for drugs to study why there is a barrier to engraftment and what interventions can change that. This is the worst part, that 62% got graft versus host disease and 38% got chronic graft versus host disease that was extensive. And that's the stuff of nightmares about morbidity, chronic morbidity, which is why this particular study did not hit one out of the park. Patients also had neurological complications, which are mostly reversible. There's a unique complications related to transplanting sickle cell disease. What is the status of adults? Remember, the first studies were in children. So 84 adults have been reported to the CIBMTR. Outcomes are still pretty good. 90% overall survival, 82% in 3 years, and then 79% in 5 years. So what's happening now is if you go to clinicaltrials.gov, which I did, and looked at all the clinical trials that are open for transplant for adults with sickle cell disease, the age limit has now changed. The median is 45 years, and the range is 30 to 7 years, or no upper limit of age at all. The important thing here is that the field is ready to offer an intensive treatment even for adults. And that, I think, is what I would take in a mixed group like this. So I'll talk to you about two studies briefly. So this study was done at the National Heart, Lung, and Blood Institute, Tisdale's group, and they actually tested this out in a mouse, and they came up with a non-myeloablative regimen. What is non-myelo? Myelo-white, bone marrow, ablative marrow, so very little chemotherapy. So they gave a conditioning regimen of anti-T cell antibody called alemtuzumab, and a 300 centigrade of TBI. So a conventional dose is like 12 to 1300 TBI. And then they used a graft versus host disease prophylaxis with sirolimus. And sirolimus, the advantage is it's not kidney toxic. It doesn't cause neurological complications. So several different innovations. So they did this in patients, adult patients 16 to 65 years of age, and from matched sibling donors using peripheral blood, and they got 87.5% long-term engraftment, and nobody died. So it's an outstanding advance in transplanting adults from matched sibling donors, at least for those 14% we have a cure now. We also presented this on Monday, and this is the results of the study that we led, and this was the pilot study of transplant in adults with sickle cell disease, and this was a mix of this was not a non-myeloablative because that doesn't work for unrelated donors. So we were able to transplant patients who had related donors and unrelated donors, and we had a 90% overall survival and event-free survival. And so we believe now that even adults can get a matched sibling or unrelated donors. What's interesting is that we did not observe high rates of graft versus host disease that was observed with that other regimen in children. So we think that whether you get graft versus host disease, how much you get, depends on exactly how you do the transplant and the details of that. So based on this, we are now doing this for the first time is actually comparing transplant to no transplant. I think the CMS went and looked at all of the data, and they said that people have done small studies, but haven't shown that what happens to people who were eligible for transplant but didn't go to transplant because they did not have a donor. So this study will actually is a multi-center 40-institution study that's going to start early in 2016. Patients will see a bone marrow transplant physician, and they will agree to have a transplant, and then they'll get an HLA typing, and they'll be biologically randomized to transplant or no transplant based on whether they do have a donor or not. So there's an exciting thing that we're looking forward to. I want to talk briefly about haploidentical transplantation. So this is a cool party trick. So typically we've done transplantation, we give chemotherapy or radiation therapy, and then we give the stem cells, and then we don't give any chemo and stuff because we don't want to hurt the stem cell that we just gave. So it turns out that the stem cell, several of the hematopoietic cells have an enzyme called aldehyde dehydrogenase, and aldehyde dehydrogenase is what you need for inactivating a chemotherapy called cyclophosphamide. So it turns out that aldehyde dehydrogenase is there in high levels in the stem cells, but not in alloreactive lymphocytes. So what you can actually then do is you can give the stem cells, the immune system responds to the foreign antigen, and there's a lymphoproliferation, and then you come and give cyclophosphamide, kill the lymphocytes while still protecting the hematopoietic stem cells. And this way they're able to overcome the barrier of HLA disparity and do haploidentical transplants. So this is a regimen out of Hopkins. So they give a small dose of cyclophosphamide. It says Cy 14.5. They give a little bit of radiation, fludarabine, give the donor cells, and then on day 3 and 4 give Cytoxan, kill off the lymphocytes, and keep the stem cells and keep them engrafted. So it's some really very exciting initial results. There are 14 patients that they've published, and they have 26 patients so far. But engraftment is about 50 to 60%. Very well tolerated. We still have some work to do, but we're able to do haploidentical transplant. This can be a game changer. And then finally, just want to let you know that gene therapy studies are open, including this by Bluebird Bio. The HPV 569, that's their first construct. This is their second construct. So they've made some improvements in their design. And what is this is how they do this. You collect the stem cells, CD34 selection, lentiviral vector transduction, and then myeloablation. So even in this, you do get myeloablation. And I'll give you some very preliminary results that were presented again this week. So there is a promise that gene therapy there's some preliminary results. One patient with severe sickle cell disease is long enough out of the procedure, is making half sickle hemoglobin and half this mutant anti-sickling hemoglobin, and the patient is actually doing better in terms of clinical outcomes. There are 2 other sickle cell patients that have had a gene therapy and are still undergoing follow-up. So excellent results. Like we talked earlier, bone marrow transplant from unrelated donors is feasible. Bone marrow transplant from adults is effective. Bone marrow transplant from haploidentical family donors is feasible. And gene therapy studies are open. Thank you very much.
I think we succeeded. Well, that's great. Krish really did a phenomenal job, both for filling in for some of our technical malfunctions, as well as setting the stage to what I hope to do is address some of the problems of graft versus host disease and engraftment. Clearly, stem cell transplant, for all the different aspects of stem cell therapy and regenerative medicine, is by far and away the largest clinical application of transplant technologies. These are the numbers of autologous transplants in the blue and allogeneic transplants in the green. In the United States, you can see it's continuously rising. The indication for autologous transplant is primarily those patients with chemosensitive hematological malignancies and germ cell cancer. Allogeneic transplant recipients are largely those patients with hematological malignancies, particularly those malignancies where the stem cell itself in the bone marrow is affected, acute leukemia, AML, and ALL. The auto-transplant maneuver depends mainly on the intensity of the chemotherapy to eliminate those cells which are chemosensitive. The auto-transplant maneuver benefits from the immunotherapy effect of donor immune cells, particularly T cells. And as Krish indicated, the donor T cells are a two-edged sword. Much as they help facilitate engraftment and eliminate malignancies, they can also cause debilitating graft versus host disease. And that's the area that we want to address. Transplant outcomes vary according to the type of graft. Unrelated donors as the source of the graft are associated with more graft versus host disease. Cord blood is a very attractive graft source because it's available on demand in a freezer, but those cord blood units are too small for 90% of adults. And even when we do use them, as Chris showed you, there can be an unacceptably high rate of graft rejection. Haploidentical transplants are very interesting, but those patients who get post-transplant cyclophosphamide have a higher rate of relapse after allogeneic transplant and often are susceptible to infections. Bone marrow grafts have slower engraftment, and blood stem cell grafts from a related donor or a matched unrelated donor engraft faster but have more chronic graft versus host disease. For those of you who are not in the stem cell field, this just illustrates the techniques we use to collect these stem cells. The bone marrow harvest procedure really hasn't changed in 150 years. It's kind of an archaic, almost barbaric procedure where under general anesthesia we put a hollow needle into the hip bone and draw back about a quart of bone marrow cells. Patients tolerate it, or donors tolerate it reasonably well, but it's a fairly technically cumbersome type of maneuver. On the right side is the stem cell harvest procedure. Technically, that's much easier. Doesn't involve time in the OR. The patient is hooked up to an apheresis machine that essentially centrifuges the blood, separating the white blood cells from the red blood cells, puts the white blood cells in a bag, which are highly enriched for stem cells after G-CSF mobilization. So how do we get these cells into the blood? And this issue is particularly relevant in the setting of autologous transplants, where we mainly want enough stem cells to reconstitute the bone marrow after giving these high doses of chemotherapy or high doses of chemotherapy and radiation, which are designed to eliminate residual cancer. Most of the stem cells are in the bone marrow, tethered in the bone marrow microenvironment to stromal cells, and only a few of them circulate into the blood. However, with G-CSF administration as an example, we can stimulate bone marrow macrophages and osteoblasts. It can then lead to downregulation of one of those tethering molecules called CXCL12, such that the stem cells are released from the bone marrow into the circulation. Adding other drugs that are a direct antagonist between CXCL12 on the stromal cells and CXCR4 on the stem cells can further augment stem cell mobilization. The net result of this is we get more stem cells in the blood where we can collect them using the apheresis procedure. So by knowing the stem cell content in the blood, it's very easy to predict how many stem cells will collect into the bag. And this is data from Emory looking at the delivered stem cell dose in the bag on the y-axis compared to the stem cell content of the blood on the x-axis. You can see, and at least in a log-log plot, there's a direct relationship between blood stem cell content and how many stem cells we collect in the bag. Left-hand panel is mobilization with 2 drugs. Right-hand panel is mobilization just with 1 drug, G-CSF. What's the optimal dose? This is obviously a relevant question from a stem cell therapeutic standpoint and will be very relevant when we move into stem cell technologies in the allogeneic setting. More is better. This is old data from the Fred Hutchinson Cancer Research Center that looked at patients undergoing autologous stem cell transplant and correlated the fraction of patients who were engrafted with platelets on the y-axis with the stem cell dose. Days after transplant are shown on the x-axis, and you can see with a low stem cell dose, less than 2.5 million stem cells per kilogram, engraftment is slow, and not all patients fully engraft. With stem cell doses of greater than 2.5 or greater than 5 million cells per kilogram, stem cell hematopoietic engraftment is much more predictable. This is similar data looking at probability of engraftment by stem cell dose, now looking at neutrophils in the top data, and again showing that a stem cell dose of more than 2.5 million CD34 positive cells, CD34 is the stem cell marker per kilogram, was highly associated with faster neutrophil engraftment as well as faster platelet engraftment in the bottom data. This matters because we've done multivariable analysis looking at the kinetics of engraftment, and those patients who never achieve a normal platelet count after an auto-transplant or whose platelet count goes up and then dribbles down post-transplant have a significantly higher risk of dying than those patients who have robust engraftment. So in a multivariable analysis, we found 4 factors associated with survival. One is achieving a normal platelet count. The second is having a durable platelet count. The third is the number of prior chemotherapy regimens. And the fourth is having active cancer at the time of transplant. So getting the stem cells to engraft quickly is just as important as the control of the cancer. And cancer is the major problem in this setting. 3/4 of the deaths after an auto-transplant come from relapse of the patient's disease. So let's turn now to the allogeneic transplant problem. We talked a little bit about how to mobilize stem cells, what the optimal stem cell dose is, but clearly the problem where we're offering curative therapy for patients with sickle cell disease is in the allogeneic setting, outside, of course, of gene therapy. So this is our Emory algorithm for how to pick donors. We prefer, if they're available, HLA matched related donors, brother or sister donors. Then we turn to HLA matched or nearly matched unrelated donors. And finally, as a fourth choice, we have looked at cord blood and haplotransplants because of the problems that Krish indicated of engraftment and graft rejection and the potential for graft versus host disease. Unfortunately, as our families have gotten smaller and yet more complex in terms of people marrying, divorcing, remarrying, having kids with multiple different partners, it's hard to find an HLA-matched related donor. Particularly in the sickle cell setting, less than 1/4 of patients are going to have an available HLA-matched sibling donor. Because of that, nationwide, the use of unrelated donor transplants has increased. You can see in the light blue line, the unrelated donor transplant number has crossed and exceeded the number of sibling transplants about 5 years ago. Cord blood in red and haplotransplants in green remain a fairly minority source of allogeneic grafts. These transplants are curative for patients with refractory leukemia or poor risk leukemia. This again shows registry data with survival outcomes from patients with leukemia. And for those patients who undergo a sibling transplant early, long-term survival at 5 years is about 55%. If we use an unrelated donor graft, survival is still very good, about 50%, but not quite as good as with the sibling donor. And that hence the programmatic decision here and elsewhere to prefer sibling donors if they're available. So what happens when the transplant doesn't work? Relapse of the disease accounts for about 1/3 of deaths after allogeneic transplant. But now, in contrast to the auto-transplant setting, we begin to see a significant contribution of death from graft versus host disease, shown in the green portion of the pie, and deaths from infections, shown in the darker orange portion of the pie. So those are failures of immune reconstitution after transplant. Graft versus host disease is too many donor T cells being too active. Infections are too few donor T cells being active enough. So somewhere between the two, we want to find a sweet spot where we get effective immune reconstitution without graft versus host disease. So to address the question of where to get the grafts from unrelated donors, we've seen that the number of matched related donors is going down, the number of unrelated donor grafts is coming up. What's the best source of grafts from those volunteer unrelated donors? We performed a randomized clinical trial through the BMT CTN where donors and the recipients were randomized to either donate and receive a bone marrow graft, the harvest procedure I showed you, or to donate and receive a G-CSF mobilized blood stem cell graft. This study was limited to patients with AML, ALL, or myelodysplastic syndrome, and it enrolled 550 patients over about a 7-year period, and the results were published a couple years ago in the New England Journal. Overall survival was essentially equivalent, and this is indeed what was predicted from the study because there have been registry data to suggest survival by itself was going to be similar between whether people got a bone marrow graft or a blood stem cell graft. But what was different is that there was a significantly more chronic graft versus host disease among those patients randomized to receive the blood stem cell graft. And that contributed to substantial portions of the deaths from graft versus host disease. In fact, a fifth of the deaths from patients who received the G-CSF mobilized blood stem cell graft were due to chronic graft versus host disease. In contrast, on the left side, 8% of the patients who died after marrow graft died of graft failure or graft rejection. The same problem Krish indicated is relevant to cord blood transplants for sickle cell patients. Well, these patients can get quite sick with graft versus host disease. This is a picture of somebody with acute graft versus host disease of the skin. It's like a terrible sunburn. It can get so bad the skin actually blisters and peels off. Chronic graft versus host disease can cause focal areas of sclerosis and scar formation in the skin and can lead to really disability where people can't move their arms or their legs, can't even take a deep breath because there's so much scar tissue in the skin around the abdomen and around the waist. So what can we do in the setting of graft engineering and stem cell therapies to improve transplant outcomes? Well, we want to get more of the good cells, the cells that facilitate survival among patients, and remove those cells which are most associated with poor transplant outcomes. And we want to optimize the use of drug therapies for patients to control graft versus host disease, but still permit sufficient immune reconstitution that patients don't die of infections. Well, as part of that published study, the randomized study of marrow grafts versus blood stem cell grafts, we analyzed at Emory an aliquot of each graft and counted the number of stem cells, of T cells, and of immune regulatory cells called dendritic cells. And we correlated the content of cells in the graft with survival of the recipients. What we found is that in patients who got a bone marrow graft, on the left side of this slide, that there was decreased hazard ratio of death, so more survival for patients who received a number of naive T cells, either CD4 or CD8, or a number of donor plasmacytoid dendritic cells greater than the median. So we decreased the risk of dying if you got more of certain immune cell subsets, particularly plasmacytoid dendritic cells. And you can see this figure summarizes some of the survival outcomes with improved disease-free survival in the upper left-hand panel of the slide being seen among patients who received greater than the median number of plasmacytoid dendritic cells compared to inferior disease-free survival compared to patients who got less. That's a pretty significant difference in disease-free survival, about 20% at 3 years. The difference in disease-free survival was due to less treatment-related mortality. And the deaths from those patients who received few of these donor plasmacytoid dendritic cells were deaths from acute and chronic graft versus host disease and graft rejection. So overall, more deaths with fewer donor plasmacytoid dendritic cells, and in particular, more deaths from failure of immune reconstitution of the graft. If you got more of both donor plasmacytoid dendritic cells and naive T cells, you did better than any other group with better than 60% 3-year survival seen among the patients who happen to receive more of both donor cell populations. So there's a sweet spot, if you like. This is kind of a clumsy cartoon. The sweet spot is that kind of large black bowling ball. But it tries to identify that there's an optimal content of different immune cells in the graft, on the x-axis being the donor plasmacytoid dendritic cells, on the y-axis being the content of naive T cells, and on the z-axis being their activation status. There's an optimal place to construct a graft associated with the best outcomes. We have a number of hypotheses about how these cells work. and to explain the differences between bone marrow grafts and G-CSF mobilized stem cell grafts. Homing of the immune cells in the recipient is one hypothesis, and the way they present alloantigen is a second hypothesis. So we've tried to test these hypotheses using some mouse models, and I'll show you these data very quickly. The first data I'll show you is that the donor immune cells, the plasmacytoid dendritic cells, survive after transplant for about 3 weeks. In this published data, we used a donor mouse which is transgenically expresses luciferase as the source of the plasmacytoid dendritic cells, or a mouse that has the same cells that express GFP, and shown in the upper panels, they're detectable in the liver as fluorescently green cells. In the lower panels, they can actually glow in the dark to the point where we can see them homing to lymphoid organs. They have, in humans, the plasmacytoid dendritic cells from bone marrow grafts have less chemokines, left of certain chemokine receptors. They're associated with more alloactivation, in particular CCR9, and more chemokine receptor, CCR7, and more CCR9 compared to the plasmacytoid dendritic cells from a G-CSF mobilized graft. So we think that the same cells from different graft sources home differently. We've looked at gene expression in these cells, comparing the cells from a bone marrow graft, from a G-CSF mobilized graft, trying to understand why the G-CSF graft causes so much more graft versus host disease. We've done principal component analysis, looking at the same cells sorted from bone marrow, shown in the gray circles, or G-CSF mobilized blood, shown in the dark green circles, or cord blood, shown in the light green circles. And we can see that the same cell population from different graft sources has a unique type of gene signature. This looks in a heat map analysis at some of the genes which are overexpressed in a bone marrow graft, plasmacytoid dendritic cells from a bone marrow graft, shown in the upper right panel. Those overexpressed genes are red, and genes which are overexpressed in a G-CSF mobilized graft in the lower left corner. And in particular, in a volcano plot, we identified FOSB as a gene which is highly overexpressed in plasmacytoid dendritic cells from a bone marrow graft compared to those same cells from a G-CSF mobilized graft. So we think we begin to identify the pharmacological targets where we can improve transplant outcomes to get less chronic graft versus host disease, less graft rejection, better survival, being able to extend allogeneic transplant to a broader range of patients, including sickle cell patients, by understanding where these cells go and how they behave when they get there, and then targeting them with small molecule drugs that can alter their behavior. So to summarize, we've looked at gene expression. We've identified patterns of gene expression pathways which regulate the behavior of these cells in vitro. These are targetable pharmacologically. These are the studies we're going on to do now to try to improve transplant outcomes. And we think that the distribution of genes suggests that each of these graft sources has unique characteristics which are predictable and exploitable based upon the source of the cells. So I'll end with this final slide just saying we're also exploring new ways of mobilizing grafts using FLT3 ligand as another way of getting the cells we want out of the bone marrow. And FLT3 ligand in particular is a cytokine which highly enriches for plasmacytoid dendritic cells into the blood. We're looking at adding back expanded cell populations and the pharmacological interventions that I discussed. So I'll end with that, and if there are a couple of questions, I'll ask Krish to come back up, and we'd be happy to answer them. Thank you for your attention.
Well, in the context of stem cell meeting and regenerative medicine meeting, how do you both foresee hematopoietic cell transplants in the future? Like, let's say 20 years from now, are we going to still infusing a bunch of cells in which a very small proportion are CD34 positive cells and the rest, who knows, immune cells?
So I'll comment on that, and I'll let Krish give his ideas. I think one is that we're beginning to understand how to expand the CD34 positive cells, not just mobilize cells from the bone marrow, but get more of them. I think SR1, which is an aryl hydrocarbon, antagonist has potently allowed expansion of CD34 positive cells from cord blood units that will allow us to use not just the 10% of cord blood units which are big enough, but potentially all the cord blood units for the purposes of transplant. Secondly, I think stem cells still have the possibility of being a vector for gene therapy. Chris showed some very early, exciting data from Bluebird suggesting correction of sickle cell anemia with a stem cell modified to express a type of hemoglobin A. But you can imagine that stem cell therapy could be used for a variety of diseases, not just correction of hemoglobinopathies, but leukodystrophies, glycogen storage diseases, where all you need to do is to deliver a little bit of the enzyme. In fact, we're about to launch a study of hemophilia where we're using gene therapy and stem cells to correct an abnormal factor VIII level. So I don't think stem cell transplants are going to go away. I do think they'll still be used to treat malignancies, particularly leukemias, but I think their application for gene replacement therapy will actually be increased.
I want to agree with everything that Ned said, but I want to point out, just add that people are actively thinking about new targets for, so we had a speaker here who, John Wagner, who spoke here yesterday, and then John was talking to us in Emory. So we're talking about cardiac, diabetes, brain disorders, stem cells. And right after John gave us a talk, we were with the genetics people, and the whole department was there, a couple of bottles of red wine and white wine, and we generated a list of diseases that are potentially targets for stem cell, hematopoietic stem cell based therapies. And the second thing I'd say is that the future is closer than you think in clinical trials.
Are we still going to be using bone marrow and mobilized peripheral blood in the future?
Well, we would like, part of the reason that we're looking at different mobilization strategies and drug therapies to redirect the behavior of the cells is try to find an alternative to bone marrow harvest because it's labor intensive and it's inefficient. And I can collect 5 people with the staff with blood stem cells with the same staff that I need to collect 1 person from the OR. Any last questions? I think we're just one more question, then we're out of time.
Hello, thank you for such a presentation, and I want to ask a question about the chemotherapy. So, as we know, secondary to chemotherapy, there are so many diseases in bone marrow or hematopoietic stem cell transplantation. So, are there any research to reduce or to completely make off this chemotherapy in the stem cell transplantation? Thank you.
So there are some approaches of using drugs that mobilize endogenous stem cells out of the bone marrow into the circulation that allow donor stem cells to engraft. So potentially, if the bone marrow contains most of the stem cells, you can think about it like a parking lot. All the parking slots are full of cars, and the cars on the road are circling around waiting for someone to leave their spot. If you get all the cells to leave the bone marrow, you create lots of new parking spots and allow new donor stem cells to engraft. So potentially, why is that important? If Krish has someone with sickle cell disease and we want them to engraft with normal stem cells, we could potentially avoid having to give them chemotherapy because a fraction of donor engraftment is enough to cure the disease. That's true for sickle cell disease, that's true for hemoglobinopathies.
And to briefly add to that, we're using less chemotherapy than we used to ablate the marrow. And secondly, there are non-chemotherapy based conditioning regimens like antibodies that are being considered. And this is particularly exciting, not only for bone marrow transplant, but also for gene therapy, because you have to meet a standard of disease severity before you can do gene therapy because you have to give all this chemotherapy. And so if you can do an antibody-based conditioning regimen, then a lot of other conditions open themselves up too.
Great. Well, we'll end there, and thank you for your attention.